the most important question here is your professional opinion. Will Abigail ever be able to talk? Okay guys, I told you that this video was coming, that we're going to do a speech and language pathology video, you know, and of course we're going to show you some of Abigail doing her therapy, but I wanted to ask the questions that we get all the time, because Abigail is nonverbal, and it's kind of a bizarre thing to have speech therapy for someone that's nonverbal. Well, bizarre, but you'll see why it's not so bizarre, okay? So this is Jill. This is Abigail's speech and language pathologist. And how long have you been Abby's therapist here?
This will be the end of our 3rd school year.
Okay. All right, so 3 years, and you're gonna be her speech and language pathologist forever, right? Okay, just making sure. Okay, first question for you. Some of these questions I pulled from our subscribers.
Okay.
You know, we get a lot of questions down in the comments, especially when we bring it up. So that's why I wanted to create this whole video.
And I've read some of them.
Yes. So the difference between speech therapy and speech pathology.
Okay. So my guess on this, because I have been taught that we are to be speech language pathologists. It was ingrained through graduate school. You're not a speech therapist, you're not a speech teacher, you're a speech language pathologist because you study and understand the disorder.
Okay.
Some people will refer to themselves as therapists. I also feel that depending, I was telling you earlier about a website, you can be a speech therapist with an undergrad for 2 years. Then you have to show graduate work. So those people might be speech therapists, meaning they have not completed their graduate studies, nor have they completed their certificate of clinical competence.
Okay.
And once you have your certificate of clinical competence, now you are a speech language pathologist.
Okay.
And you've completed your graduate work.
What level of education do you have then?
So I have a master's degree.
Okay.
It is through ASHA, the American Speech Hearing Association. You have to have a master's degree to be a speech pathologist. Each state has their own rules. So as I was saying, you can work typically for 2 years with just an undergrad, and those typical sites would be in the school system. Once you hit that 2-year mark within the state of Florida, then you have to show that you're enrolled in a graduate program.
So you're a master talker then?
I am a master communication disorders.
I got you.
Communicative disorders.
That's impressive. So, okay, so as far as the percentage of speech and language pathologists that are at your level,
Yes.
is that most?
Yes.
Okay.
Because you can't work.
Right.
I joke that
You have a limited amount of time
Right.
in that, okay.
Like I got out of undergrad without acceptance into a graduate program.
Right.
Each graduate program, regardless of the size of the university, is capped at their amount of enrollees because of the American Speech Hearing Association, and it's typically between 32 and 35. Well, undergrad programs are putting out hundreds of students every year, but only a small percentage are actually getting into a graduate program.
Okay.
So I would joke back then, so many years ago, that great, I have this BS, but I can't do anything with it.
Right.
Because I need to get into a grad program.
Gotcha. Because we have a lot of people, a lot of subscribers and viewers that are interested in some field of therapy. You know, our videos tend to push people in that direction because they want to be part of this.
Right, the helping industry.
Yeah, exactly. So, so that's good information. Perfect. Okay, question number 2. What are the initial goals with a nonverbal client? Like, what's the first thing that you want to establish and work towards?
Okay, so we typically consider the motor planning of a nonverbal. Why are they nonverbal? Is it because they don't have airflow? They can't supply enough air to get out from the diaphragm and up out of the mouth? Or is it a motor planning issue? What is going on that child is nonverbal? Because typically they're showing us intent to communicate in other manner, whether it be gestures, pulling, pushing. They're letting their wants be made. So I want something to eat, I'm gonna take you to the pantry. However, when I look at a child who's nonverbal, I look to see what we call their oral placement. How are they moving the muscles of their mouth? So can we imitate motor movement? Can we imitate sounds? It doesn't mean we're imitating words, but can we imitate just vocalizations, just an ah? Can we do that on command? And if we can't, why can we not do that? So I do a combination of oral placement therapy and prompt therapy. So I'm looking at a nonverbal child through time. Are they apraxic? Do we have a neurological disconnect between brain and muscle.
Okay. A lot of this stuff's going to apply to Abigail because that's what I know, and
Right.
that's kind of what we're talking about. But
That's why you're
as
here.
far as how her sessions look, how long are her sessions? Does she get breaks, that kind of thing? What is that? Paint a picture for me.
Okay, so here at Jacksonville School for Autism, she is seen within her classroom setting. So I don't see her during her clinical one-on-one ABA unless we're doing a type of co-treat for carryover.
So it's all push-in.
It's all push
for
into the
her.
classroom.
And do you prefer push-in?
It depends on the student. For
Okay.
Abigail, if I was to pull her out of her classroom, now I'm wasting time taking her from her classroom all the way upstairs to my therapy room, where there's a lot of things she could get into.
Right.
Where in the classroom I have control more so because it's a room she's more comfortable with.
Transition tends to lead to hype
Right.
for her.
And so why am I going to
She gets hyped on transition.
Right. I need her to be controlled because I need to get to her muscles.
Yeah.
And in her classroom, I will put her at a table where I can kind of corner her in, but I'll also read her body language. If she's starting that hype, we've been sitting here too long, Jill. Okay, we're going to let her get up and walk and come back.
Right.
Within our classroom, I also have her teacher support and her paras. So often I will let them redirect her back to me, and
Okay.
I will stay put because I'm the one that has to be in her face.
Right.
For Abigail, it's 30 minutes. Insurance would allow an hour, but because we're pushing into the classroom, we do 2 30-minute sessions a week is the ideal schedule for her. We do breaks based on what the child needs. Sometimes I'll say we're gonna finish this set of tools, and so she can visually see what we're finishing, and then you may have a break. And typically her breaks are I just want to get up and move.
Right. Okay. You've got some weird things going on in your little box of treasures.
Yep.
Can you explain some of your toys that you
Yes.
have?
So each session it's oral placement therapy through talk tools. It is a hierarchy of tools. So we're looking at the system as to how the whole system works together. Every session starts with sensory because she needs to be prepared for me to be physically touching her. So I always start with the sensory beanbags just to desensitize the outside. I'll do a little bit of Beckman stretches, which is another whole protocol, Beckman oral motor stretches. Then we go to the Z-Vibe, and now I'm going into her mouth and I'm desensitizing. So I am going into the cheeks and I'm going to the lips, I'm going to the outside. We're going to the tongue to make sure that her tongue is ready for what we're gonna do. We have chewy tubes because we want to see the strength of her chew for jaw movement. We have those red or purple bite blocks because we want to look at jaw grading. We all know, children who have either a really tight jaw or really open position. So knowing that my jaw has to move different heights based on different sounds. We can't say E if our mouth is open. We then will do blowing. We do blowing through the horn hierarchy as well as bubbles. And the reason for that is just think of how much you have to do to blow. Depending on the horn or depending on the bubble, we have to round our lips, we have to protrude our lips, we have to retract our tongue back. And then we have to have this strength of airflow that comes out. And it has to be a nice smooth pattern, which is everything we need for speech.
Right.
We can't talk in small syllable breaths because we sound robotic. So we want to start with that foundation, that good, the base of the house has to be strong. So we have to have that strong belly strength to get airflow.
It's not something you think about until you see it happen. How much exercise goes into just getting the mouth moving like it needs to prep it for
Right.
working on speech.
Right.
Because it's Abigail doesn't use her mouth for anything other than she does make
Sounds,
vocal
yeah.
sounds, and she does eat with it, but she doesn't form words, so she
Right.
has to go through those motions. And then so there's a large sensory aspect to speech and language pathology.
Well, and Abby has a lot of medical background, the anatomy, the physiology of it.
So far we've had a plane fly over, a helicopter fly over,
And now we have kids.
several semi-trucks, and now we have a swarm of children taken to the playground. So we'll see how great the audio is on this one. So when you're working with her and you're moving her mouth around,
Yes.
you're manipulating her lips and things like that. Why?
Okay.
Why do you do that?
So
'Cause that's weird.
That's weird. Remember I did it to you at that first
Yeah.
IEP meeting.
Like first time I met you, almost you
Yes.
were like moving my mouth around.
Well, it's because it's a different type of therapy. So that's called the prompt technique. And if your viewers go to the Prompt Institute, they will find that technique. It's a very unique technique that's only taught to speech pathologists. We're not supposed to share this with families or other therapists. And the idea behind that is also connected to the apraxia. We want the brain to reconnect how muscles move for certain sounds. So if I put her lips together for B, P, and M, what we call bilabial sound, all of those are done by closing our mouth. But they're also done at different speeds and different frequency. So the P is considered a plosive sound, so it's fast.
Right.
Versus B.
Okay.
And then our airflow changes and it becomes a nasal. So I'm doing hands-on prompt for her muscles to feel the movement that's needed for those certain sounds, so that we can have a reconnection.
Okay. So you
Now we have a swing.
yeah, that's fine. I mean, well, it's funny because we're used to
Yes.
constant noise and
Oh, yeah.
things going on around us, and
We can focus through
but
this.
we'll see how it works. Are you guys paying attention still? You able to keep up with all this going on? Okay, the Dynavox, sensitive subject right now.
Yeah, a little PTSD here.
A little sensitive subject with the Dynavox. Abigail, if you guys don't know already, Abigail was turned down for her communication device, denied by insurance. We're still working on it. The fight is not over, of course, but we're working on that currently. But that being said, how does a communication device work into what you do?
Okay.
Because one would assume that you guys would be like mortal enemies, communication device and speech and language pathologist, but in fact, you're the one working to get her that.
Right,
that,
she has to
that
have my
device.
license to get it.
Right.
So we believe in a philosophy of total communication. We talked about how a child will gesture, they'll point, they'll move the person, they'll bring an item to the person. So that's one form of communicating. Then we have simple sign language, we have vocals, we have, and then in addition we have our augmentative communication, our speech outputs. So right now we want Abby, we want her needs met. We want her to tell us what she wants, what she needs, and eventually growing that into her education so she can answer questions about a story or a movie that she watched, or saying hello to somebody or asking somebody how they're doing. Right now she doesn't have the ability to move her muscles to get those sounds into words. We know she can do ma 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 ma, and we know she can do the sound, but that hasn't formed into a true communication.
Right.
So we need to respect who she is as a person.
Sure.
And that she's got feelings and wants and needs.
Well, another way I like to think about it too is it's not one or the other.
No, it's
And
all.
it's kind of like and one assists the other. Absolutely. If Abigail can learn to use her Dynavox efficiently, she then has more understanding of words
Correct.
and how things sound because her Dynavox is speaking to her. So it's kind of like people that learn to play an instrument. The second instrument they learn to play, they learn so much
Moves
faster.
Right.
So,
Well, and it gives people an understanding of her competence.
right.
There's too many people that don't believe a child who is nonverbal or has the sensory that she portrays is as smart as she is.
Right.
And it's going to give others the knowledge of she's got a lot to say to us.
Yeah.
And we're not finding out how to. We don't know.
Yeah.
She doesn't have a way, and she needs to have a way. We need to respect that.
Agreed.
And we're not giving up on her vocals. We just want it faster.
I got you. The swings stop right as we're concluding
know.
our interview here. Okay.
And they're quietly going in.
What is the ultimate goal for someone who is nonverbal like Abigail? Like, what is your? I'm not talking lofty like dreams and stuff. I just mean, a reasonable goal.
So a reasonable goal for where we look right now is that she would be able to move the muscle she needs to form simple power words such as no, mama, dada, bubba, maybe for Isaiah.
Right.
Something that she could get her needs quickly met. I mean, a no is that our children learn no for a reason. It's power.
Right.
More, eat, simple things. But in order for her to do that, there's a lot of work that has to be done. And as long as she keeps cooperating, we're not giving up. She's gonna get there. I've had patients get there. I've had patients that can come up and say Coke because he wants a drink,
Yeah.
and he's 14 now.
So that leads us into my final question, the $1 million question, the one that everybody asks us every single live chat Q&A session. We get this question. Your professional opinion, because I am just a dad. I don't have a master's degree.
Or 17 years experience.
the most important question here is your professional opinion. Will Abigail ever be able to talk?
So my token response to this, to make you giggle, is I know I look like an angel, but I'm not God.
Right.
I wouldn't be in this field and I wouldn't be working as hard as I'm working with her and any other patient if I didn't believe that there's a possibility. And I wouldn't be giving parents that hope and that dream if I didn't believe it. Do I see progress? I do. She couldn't blow a horn when we started. She could not motor plan to pull her tongue back and round her lips and blow air. She couldn't do it. And now we're on horn number 2. So we still slide back to horn number 1 for strengthening.
Right.
But that's progress. That's what we want to see. That's motor planning, and it takes motor planning to make sounds, and it takes sounds to make words. So, do I know? No, nobody knows. So we're just going to keep working really hard so that we can see what her future holds, so that she can tell us what she wants, even if it's just no.
It was an awesome no commit answer.
I can't commit.
I won't hold you to it.
I really like my job.
That makes total sense. I mean, I agree with you. You know, the chances of Abigail ever living on her own are relatively slim. You know, being totally independent. But we still work towards independence every single day.
Exactly.
So.
And do I know that she'll be having conversations like you and I are having? I don't know. But that's not where my head is right now. Right now my head is simple sounds, combining sounds into making a word.
Awesome. Thank you so much for your time. I really, really appreciate it.
Yes.
This is a good conversation.
We'll do it again.
This is the science of it just blows my mind. It's super interesting to me. So I hope you guys found some interest and value in it as well, because you have a cool job.
I do.
You have a cool job, and you get to work with my angel every day.
Really cool kid.
Yeah.
Even if she does my hair.
So much personality in that one. All right.
All right.
You rock. Thank you. Well, you know, I work very hard. I think about you when I'm brushing her teeth in the morning and helping her brush her teeth. Like, you got to do a good job, Abby, because you're going to be in Miss Jill's face.
And I see her after lunch, so it's what Priscilla cooks for lunch. So I'm like, ooh, you had something good, because there's garlic. I always ask the girls that. I'm like, what'd she have today?